Welcome to the next video that will be focusing on second-line therapy and later for HER2-positive gastroesophageal adenocarcinoma. In the recent set of videos, we've been really focusing on the stage 4 unresectable disease, also referred to as palliative therapy. And we've been taking you through my mind map of how I think about going through therapy after being diagnosed through the various lines of therapy. We spent a number of videos on the biomarker-directed therapy in first line, including HER2-positive disease, where we looked at chemotherapy with 5-FU and platinum, preferably FOLFOX, with trastuzumab, and also talked about the newest study, Keynote 811, showing the addition of immunotherapy, pembrolizumab, and its benefits. We've talked about first-line maintenance therapy, and that applies also to HER2-positive disease in terms of dropping and adding the oxaliplatin to limit the cumulative neuropathies, and then only when there's failure on this first-line therapy that it's no longer working or the neuropathy becomes intolerable and it's not working in maintenance anymore, that a transition to next line is appropriate. We talked about second-line therapy then in the most recent video, specifically for HER2 negative, but also HER2 positive disease was eligible. And that was with the Rainbow phase 3 study that then established paclitaxel and ramucirumab as a standard second-line therapy. One thing I didn't mention in that video is that in large phase 3 first-line studies, only about half of patients go on and receive second-line therapy. And the reasons for that include rapid cancer progression to the point where the patient is not really a good candidate to continue on therapy because they're more frail, they're weak, and they're not a good candidate to do so. And the treatment that they're going to be receiving in second line, they wouldn't be strong enough to take it. Similarly, when transitioning to second line to the next line, only about a third of patients go on and receive that third line therapy, and even fewer, obviously, for later lines. So this is an important concept to understand, is that there is drop-off, and usually due to cancer progression to the point where patients are no longer able to go on and tolerate other palliative therapy regimens. So there's something to say then about an experienced physician treating this cancer at each of these transitions between first line and second line and third line, that treats this cancer frequently, understands how it progresses. Sometimes it progresses sort of under the radar. And so close monitoring during the maintenance phase and treatment phase on that first line therapy to really make sure that we don't miss the window of opportunity to switch to effective next line therapies, whether it's between first and second or second and third. And so, of course, we don't want to switch too soon. We don't want to burn a bridge when we have relatively limited options over the lines of therapy. We want to use each line to its fullest, but at the same time, we don't want to keep it on too long and miss the chance of switching to second line. And that, in a way, is an art, and comes with, again, a lot of experience with treating this cancer and knowing exactly when the opportune time is to switch. So it's important that, even though in large phase 3 studies, we recognize only about 50% of patients go on to get second line, and around 30% go on to get third line, and far fewer even at later lines. In my practice, for example, in the Pangea study, which was a sequencing study through multiple lines of therapy, and we'll bring it up again later in this presentation, is that the rate of transitioning to second line was around 80% of our patients in that study, and I think around 40% of patients that went on to get third line. So, I think that supports the notion that when we are paying attention, patients are being seen frequently enough to really pick up early progression following tumor markers, ctDNA, between scans, and of course, having visits to report symptoms to detect early clinical progression are all ways to adjust each line of therapy and switch, if appropriate, earlier than the planned time of a staging scan, for example. Very important aspects to consider. So that said, though, if a patient is eligible and willing to continue on further therapy, we're going to now be focusing on specifically what we might consider doing in second-line therapy for HER2 positive cancers. And also, we're going to bring into the conversation third-line therapy, and you'll see in a moment why we'll be sort of talking about both of these in this video. One concept that we're going to bring up that we've also talked about in previous videos when we addressed the molecular heterogeneity within a patient in terms of different sites in their body having different genetic changes in different cancer cells. We're going to be focusing on the reasons why we would consider confirming at the time of progression on first-line therapy and before starting second-line therapy that the cancer that is growing is actually still HER2 positive. And one could also say that when changing from second to third line, to also consider checking if you're going to be starting an anti-HER2 therapy to ensure that the patient's tumor actually is driven by HER2. Now, remember when we've talked about the different subgroups of this adenocarcinoma, when we talked about the 4 cancer genome atlas classifications, we focused on the chromosomal unstable subgroup because it's so common in both the esophagus and G junction adenocarcinomas as well as the stomach adenocarcinomas noted here in purple. And we also talked about how for the chromosomal unstable subgroup, gene amplifications of various oncogenes is common. And you can see here that HER2, also known as ERBB2, is quite common, particularly in the chromosomal instability subgroup. So overall, when you look at all of gastroesophageal adenocarcinoma, the incidence is about 10 to 15%. But if you look specifically at that chromosomal unstable subtype, it's a higher percentage, 20, even 25%. In summary of first line quickly, just to review, and also there's some pertinent updates about the HER2 positive first line setting that I'm going to go through here. This is what we expect in the first line setting with chemotherapy in terms of outcomes, response rate, disease control rate, progression-free survival, and overall survival with chemotherapy alone. And then, of course, in the HER2 positive subgroup, we know that adding anti-HER2 therapy with trastuzumab improves on each of these. And we also talked about a number of different ways to inhibit the HER2 pathway. The HER2 pathway here denoted in green is the HER2 protein that spans across the cell membrane. And this HER2 protein becomes activated when it binds to other proteins like HER3 at the membrane. And that activates the internal tyrosine kinase domain of these receptors that then leads to a signaling cascade through other proteins, goes to the nucleus of the cell, and alters the DNA transcription, turns certain genes on, other genes off, that tells the cell to grow and invade and divide and become cancerous. And so chemotherapy, of course, inhibits the DNA synthesis and cell division that we talked about in previous videos, and that HER2-directed therapies like trastuzumab all have ways to inhibit this signaling transduction. So trastuzumab binds to the outside of HER2. We've talked about pertuzumab, which is an antibody that binds to HER3 and prevents it from binding to HER2 and prevents the activation. We've talked about antibodies like zanidatamab or ZW25 that bind to both the HER2 site and the HER3 site as a bivalent antibody and sort of act like trastuzumab and pertuzumab together. We've talked about internal tyrosine kinase inhibitors that come in, usually are oral, and come inside the cell and bind to the inside tyrosine kinase domain and turn off the ability of the receptor to continue that signaling cascade. We're going to point out tucatinib in a moment. And then we're really going to be focusing on antibody drug conjugates, which is an antibody bound to a chemotherapy, and the antibody brings that chemotherapy to wherever it's intended to bind, and then the chemotherapy gets internalized and affects the cellular function at the level of the DNA. And so we're going to point out one such ADC, or antibody drug conjugate, called TDM1. But most importantly, we're going to be talking about TDXD, or trastuzumab deruxtecan, also known as HER2, which is the only approved, FDA approved anti-HER2 therapy for later line gastroesophageal adenocarcinoma. Just a quick reminder about how we test for HER2 positivity. There's a combination in the algorithm of using both a protein-based assay, immunohistochemistry, or IHC, along with a gene copy number assay, FISH, fluorescence in situ hybridization. And it's an algorithm that's used so that if the IHC is very high, the highest level being 3 plus, in at least 10% of the tumor cells, then that's considered positive and no further testing required. On the other hand, if the IHC is low, at 1 plus or negative, then this is considered negative and no further testing is required. It's only when it's equivocal in the IHC, where it's in between that at an IHC level of 2 plus intensity in at least 10% of the tumor cells, that then reflex testing by FISH analysis, and only if the ratio of gene copy numbers of HER2 to the actual number of chromosome 17s in the cell, if the ratio is above 2, then it's considered amplified. And so that would be considered positive. In addition to doing the IHC and FISH, another way to assess for HER2 positivity we talked about is with next generation sequencing of the DNA obtained from samples. And specifically, although we're looking at all the mutations, all the 4 main classes of genetic alterations, HER2 gene copy number alterations can be identified. And of course, we've talked about a number of different assays that are commercially available or available at academic centers that will be able to assess for all of these aberrations, including for gene copy numbers like HER2. So with that said, is a quick review. What do we do in first line for HER2 positive cancers? If they are HER2 positive, then they were treated with chemo with or without trastuzumab in this TOGA study, and that showed a clear survival benefit and progression-free survival benefit, and that led to FDA approval based on the eligibility criteria of having either a high immunohistochemistry score of 3 plus or a FISH positive score, irrespective of what the IHC was. So in this definition, IHC 0 and 1 plus FISH positive tumors were considered eligible, but as I'll show you in a moment, they didn't seem to drive much benefit. And so that's actually not what is done today. That's shown here in this forest plot. Remember, a forest plot looks at everyone that's enrolled in the study and shows whether or not there's benefit to the study agent versus no benefit. And you can see in the overall group that there was a benefit. But when you look at the subgroup analysis in the forest plot by different levels of expression and whether or not the FISH was positive or negative, you can see different outcomes based on those subgroups. And in another analysis, lumping those patients that were at high level expression and FISH positive compared to those that were at low level of expression and FISH positive, you can clearly see that the benefit is solely in those patients with higher level of expression. And you can see that their benefits are more profound. And specifically, the one that drives the outcome the most is those patients that have the highest level of expression, 3 plus and FISH positive. And you can see that this is the most pronounced benefit of all the patients there. So this is shown here on this figure where we're plotting the median overall survival. So that's just the median. There's a wide range here on the median. I always like to remind us that, but the median of best supportive care without any chemo going back years ago, that the median survival is around 3 months. Then adding various chemotherapy regimens, the median overall survival range from 8 to 12 months. Most recently, studies are showing that it's around 11 to 12 months with chemotherapy alone. And then we have the TOGA study looking at all comers in that study based on that original criteria of if you're FISH positive, you're eligible, or if you're IHC3 plus. And you can see that in the control arm, the median overall survival is pretty similar to what one might expect with chemotherapy alone. But in the trastuzumab plus chemo arm, you can see that they had added benefit. However, when you look at the subgroup analysis that we showed, and parsing out those patients that have the really low expression and FISH positive cancers, there's really no benefit. In fact, the medians are a bit longer in the control arm compared to the trastuzumab arm, whereas the benefit is seen solely in those patients that have highest levels of expression. And then if you compare the IHC3 plus versus the IHC2 plus when they're FISH positive, the most benefit is really from those patients that have the highest level of expression. And we see that over and over again. And I'm reminding us in this video because that's also the case in later line, as we will see. Now, the other important thing to recognize is that the FDA approved treatment based on the original accrual. And so all patients that were eligible for the study are technically FDA approved. That said, the NCCN guidelines recommend treatment only to the patients that have at least IHC2 plus and FISH positive disease, and not those patients that are FISH positive but without any expression. So these are some important reviews about first-line therapy. Now, what about other first-line therapy that we talked about briefly? We talked about the LOGIC study, which looked at chemotherapy with lapatinib, a tyrosine kinase inhibitor that's oral and added to the chemotherapy backbone, versus a placebo of lapatinib. And you can see that this study overall was negative. There wasn't a significant difference in overall survival. The reasons for this are maybe many, but some of them I've listed here is that when you look at certain subgroups that specifically Asian patients, younger patients, but in my opinion, the most important, those patients that have the highest gene copy number and the highest expression of HER2 seem to derive benefit from the addition of anti-HER2 therapy to the chemotherapy. The likely problems in this study are that at the time that this study was conducted, patients with low-level expression were still eligible for the study, and about 20% of the patients enrolled here were really HER2 negative and wouldn't derive much benefit from this. In addition, we've talked about the problems with discordance of a local pathology review versus a central pathologist reviewing, and that there's not 100% concordance with that. And so often the central pathologist will overturn a call from a local pathologist. And so the eligibility, though, was based on the local pathologist's review. Similarly, baseline heterogeneity of the primary tumor versus metastatic sites is a problem we've talked about in previous videos. And so some patients may not actually have a large burden of HER2 positive disease in their cancer, and so not likely to benefit much from anti-HER2 therapy. We've talked about lapatinib not having the ability to recruit natural killer cells like trastuzumab. And so trastuzumab tends to have a better outcome when compared directly to lapatinib for that reason. And so this may be explaining why the TOGA study is positive, but the LOGIC study, it was negative. And then also just the tolerability of lapatinib plus chemo is a little bit harder to tolerate than trastuzumab plus chemotherapy. And so maybe more patients came off the treatment sooner and weren't able to derive as much benefit. So these are all potential reasons, maybe a combination of that, why lapatinib was not a positive study in the first-line setting in this LOGIC study. Similarly, there was the JACOB study, which was a study looking at pertuzumab, which remember is an antibody that binds to HER3 and prevents it from dimerizing with HER2 and activating HER2. And so this was a study looking at the TOGA regimen with or without pertuzumab. And you can see here that the pertuzumab arm in red was trending to being better, but it wasn't considered statistically significant. And so some reasons why this could be considered a negative study or didn't make a positive study is that a large proportion of patients were actually in that equivocal HER2 positive zone of 2+ FISH positive, so about a third of patients. So In other studies, this may be as low as 15 or 20%, and that can make a difference. Similarly, it's not a small study by any means, but compared to some of the larger phase 3 studies that have been conducted in the last 5 years, say with immunotherapy, say, for example, Checkmate 649, which is a massive study of more than 1,500 patients. This study, by comparison, is quite small, and therefore remember in the videos on clinical trials with statistics is that this smaller size study can't statistically scrutinize smaller differences. And so if this study, in other words, was a lot bigger with more patients and the same result was observed, it would be called positive and it would be considered a positive study. So these are all potential reasons why Jacob in the first line setting with pertuzumab would be considered negative. So the reason why I bring this up is because in breast cancer, the same studies, which were conducted a little bit earlier in each case, other than the TOGA study and the first breast cancer study with trastuzumab in first line, where both of these studies in green here are positive, the LOGIC study and the Jacob study were negative compared to the corresponding studies in breast cancer. Why? Why would they be positive in breast cancer but negative in gastroesophageal cancer? Well, suffice it to say they're different cancers, but I really think that it's different biology, and a key component of that is that there's heterogeneity in the patient, with some cells being HER2 positive and some not, which happens to a much higher degree in gastroesophageal cancer compared to breast cancer. This has a relevance now when we talk about second-line therapy, the topic of this video. And just to round it out, what we're doing in first-line therapy is a more recent study called Keynote 811, and there are some updates to this. That's why I'm including it here since the last video we did on HER2 in the first line. And that is, this was a phase 3 study. It is completely accrued, and at an interim analysis with a size of about a phase 2 size of patients that had data available for evaluating response rates of the treatment was reported. And so remember, this study was looking at the TOGA regimen with or without pembrolizumab, the Keytruda anti-PD-1 therapy, or a placebo. And so what it showed was that there was a just over 20% increase in response rate in the patients who got pembrolizumab versus placebo. And you can see the waterfall plot here of the pembrolizumab in blue versus the placebo in red, where there's a decent response rate and shrinkage rate with just the standard TOGA regimen. But each of these responses seem to be a little bit deeper, and there's more complete responses. And the median duration of those having a response was almost 11 months. So this led to an accelerated conditional approval, meaning it has to show the results in the larger phase 3 group later, and the progression-free survival and overall survival primary endpoints. But in the interim, this was an accelerated approval to make it available for patients. I've been vocal about the issue about biomarker selection for PD-L1, especially in HER2 negative tumors, but also in HER2 positive tumors. And this is, again, a forest plot of all of the different subgroup analyses of this Keynote 811 study. You see the overall is at the top. And so remember, the zero line in this case is showing that there's no difference between the pembrolizumab arm on the right in this case versus the placebo group on the left. And what it's plotting is the response rate difference comparing the arms. So overall, there was a 22.7% increase in response in favor of the pembrolizumab over placebo. And you can see that all the various subgroups have similar improvements in response, all except the low PD-L1 score. The low PD-L1 score has no statistically significant difference of improved response. Now, the critic would say, well, this is a very small subgroup and it's subject to random variation. And that's all true, except that every time this subgroup analysis is assessed in every single study, it shows the exact same thing. And so it becomes much more plausible to believe this. So regardless, in addition to that, this is the lowest cutoff, if you recall, of what you call positive or negative for PD-L1. The higher the expression, the more likely you're enriching for those patients who would benefit. And the real question to me was, if you make the cutoff at higher levels, you should see a much improved benefit, more pronounced benefit in the higher levels and no benefit in the lower levels. And we haven't seen that information yet on the original analysis, nor on the follow-up group. But what I want to point out is that this is only just response rate. What we're really looking for in the end is, does this translate into a survival benefit? Is it controlling the cancer for longer, progression-free survival, and are patients living longer, overall survival? And is there differences by the PD-L1 cutoffs? So the update that happened since the last video on this came as a press release in a few months ago, and that is shown here, that in the pre-specified analysis, looking at progression-free survival now, a longer follow-up, and in the whole study group, not just the phase 2 group, what was seen was that the improvement in PFS was limited to patients who had a PD-L1 positive tumor by the CPS greater than 1 score. In other words, it's not working in those patients with a PD-L1 score less than 1. And so the other important thing is that, according to this, it appears that the FDA will be amending that accelerated approval, which, remember, was for any patient with HER2 positive cancer to be eligible, to now only those with PD-L1 scores of 1 or higher. And so that's important. And you can see then that the progression-free survival doesn't show benefit in those less than a 1. And that said, about 80 to 85% of patients will have a score of at least 1 or higher. And so again, the real question to me is going to be, what about higher levels? Are patients that are less than 5 and above 1, or less than 10 and above 5, really deriving any benefit from this or not? And that's just with PFS. In addition, while you see here, there was a trend towards improvement in overall survival, this indicates that it was not statistically significant. Now, with further follow-up, this may convert to being statistically significant. That said, I really will be looking and paying attention to the subgroup analysis to see if there's benefit in the highest level groups, which is where we would expect there to be benefit for this agent, pembrolizumab. Okay, so lastly, in the most recent videos, we've been talking about maintenance therapy in the first-line setting, and a balancing act of trying to control the cancer and its symptoms and limiting side effects so that we can optimize the quality of life. And one of the strategies to do that, as was mentioned, we can drop in and out various components of the chemo, whether it be the oxaliplatin or the full chemo, if we can afford to, with a treatment holiday. This all applies also to HER2 positive cancer, where you would also be continuing the trastuzumab and the pembrolizumab, if you're on it, as well during the maintenance phase. And we would continue doing that until there's either cancer progression on the full chemo or cancer progression on the maintenance therapy, but we can't resume the full chemo. We talked about neuropathy as a common reason for that. And regardless, at some point, we would expect, in most cases, certainly not all, but most, that eventually there will be a development of resistance, the treatment will be deemed no longer working, and then it will be time to change to second-line therapy. And so that's summarized here, what I just mentioned. If there's obvious cancer progression on full or maintenance, but you can't resume the oxaliplatin. And then lastly, I always qualify that even if we can't objectively see progression on scans or tumor markers, but there's a strong suspicion of clinical progression based on cancer-related symptoms, then of course that would be grounds to switch. And this, of course, is similar whether or not it's HER2 positive or negative, but in the HER2 positive space, I've just added trastuzumab with or without the anti-PD-1 therapy, pembrolizumab in this case, in this setting of HER2 positive cancer. Again, the setting of second-line therapy for HER2-positive therapy is the same as HER2-negative in the goals of care, which are the same as in first line, which is to try and control that cancer as long as possible and improve quality of life as long as possible, but limiting side effects along the way. In the second-line setting, in the most recent video, we talked about the benchmark now with which all other newer therapies should be compared, and that was the pivotal randomized phase 3 study in second line called the Rainbow study, which was evaluating paclitaxel with or without ramucirumab. And the outcomes of response rate, progression-free survival, and overall survival in all those patients are listed here. It should be noted that about 6% of the patients enrolled in that second line study had received trastuzumab in the first line setting and were therefore HER2 positive. And of those patients, it's a small subgroup analysis, but you can see that their benefits seem to be, if anything, better than the HER2 negative patients. So patients who got ramucirumab and paclitaxel had a response rate of 45% compared to 11% with paclitaxel alone, et cetera. And so you can see that overall, HER2 positive tumors seem to do very well with paclitaxel and ramucirumab. And so that should be considered a standard of care in the second line setting. We also talked about the chemotherapies, irinotecan and taxanes and combinations that could be used in second line, and the studies that supported that, which predated even the Rainbow study, showing that chemotherapy was better than best supportive care in these two studies. And we also saw that ramucirumab or Cyramza as a monotherapy in the Regard study compared to best supportive care showed some benefit. But it was really the important Rainbow study shown here looking at paclitaxel with or without ramucirumab. And again, that's the study that now serves as the benchmark for second-line therapy. You can see here that it substantially increased the response rate to nearly 30% and the disease control rate around 80%. So these are the benchmarks to compare any newer therapy. And again, I'll just highlight that subgroup of patients in the Rainbow study that were HER2 positive, that had trastuzumab in first line, that then went on to get either paclitaxel and ramucirumab or paclitaxel alone. And you can see that they derive substantial benefit from ramucirumab and paclitaxel. Just also to review that we can also use other agents besides taxane, particularly irinotecan or FOLFIRI. Why would we do that? We talked about how we are trying to eliminate worsening neuropathy, which taxanes can cause, or if a patient had a prior taxane in the perioperative setting or first line setting with, say, FLOT or DCF, then obviously giving more taxane in the form of paclitaxel after, say, docetaxel really makes a little bit less sense than changing altogether to a different regimen like irinotecan. In this retrospective analysis, it showed that the outcomes would be similar to what we would expect with paclitaxel and ramucirumab by using FOLFIRI and ramucirumab. And in this phase 2 study, which was then published after that retrospective analysis, comparing FOLFIRI-RAM versus paclitaxel and RAM, showed really no differences in outcomes. And that said, patients who had a prior taxane with docetaxel seemed to drive a little bit more benefit with the FOLFIRI compared to the paclitaxel, which makes a little bit more sense. So this supports the use of the consideration of irinotecan-based regimens in place of the paclitaxel in second line. And so that brings us to the NCCN guideline table, which explains why each and how each of these regimens are listed here. And then lastly, when we talked about second line maintenance therapy, we alluded to the fact that the dropping in and out of oxaliplatin is not unique to the FOLFOX regimen. We can do that with other regimens like FOLFIRI by dropping in and out the irinotecan to limit cumulative side effects like fatigue and weakness, or with paclitaxel on and off with just the ramucirumab to limit the buildup of worsening neuropathy. So maintenance therapy can apply in any setting, in any line, not just first line. Okay, so then that brings us to what about specific treatments for HER2 that are targeted treatments as opposed to more general treatments where they were eligible for those studies but is there any evidence of other HER2-based therapies in second line or higher? So before we get to trastuzumab deruxtecan, which you saw on that previous slide, is the only specific HER2 targeted therapy FDA approved, we'll talk about a few studies that were negative in the second line. These are phase 3 studies that were looking to add anti-HER2 therapy to the standard of care at the time. So the first study is called the Titan study, and this is a study looking at paclitaxel with or without the small molecule tyrosine kinase inhibitor lapatinib. And you can see here that this study, unfortunately, was negative. So it didn't seem to add benefit after getting first-line therapy with the TOGA regimen, trastuzumab, and then proceeding on to second-line therapy. It didn't seem to help. However, there was an improvement in response rates in this study. Nearly 30% of patients responded with lapatinib and paclitaxel versus only around 9% with paclitaxel alone. Most importantly, in my opinion, when you look at the patients that had really high expression of HER2, the IHC3 plus, as opposed to the IHC2 plus FISH positive, then you see the survival curve showing a benefit in terms of improvement with lapatinib. And although the response rate wasn't reported for just that subgroup, you would imagine that the response rate was a lot higher than in the all-comer group after excluding the IHC2 plus FISH plus patients. And it may be even on the order of 35 to 40% of the patients having a response. So these are explanations as to why overall this study was negative, but that there was suggestion of subgroups that could derive benefit from anti-HER2 therapy. So additionally, things that could have led to negative outcome of this study is that, again, lapatinib does not have that immune stimulating property like trastuzumab. It does add toxicity on top of paclitaxel. It's a little bit more difficult to tolerate than, say, trastuzumab and paclitaxel would be. And of course, a big one is temporal spatial heterogeneity, which means that over time, even if HER2 positive at the beginning before first-line therapy, after first-line therapy, before second-line therapy, a large proportion of patients may not have HER2-driven cancer. And in this study, in this era, it was not routine to reassess and ensure they're still HER2 positive. They were just assumed to still be HER2 positive based on their diagnostic biopsies. And so a large proportion of these patients, as you'll see, ranging from 30% to even 70%, would actually not even have HER2-driven cancer anymore. So this would be a clear reason why HER2-directed therapy wouldn't be effective here. Now we move to the second-line study called the GATSB study. And this was a study looking at an antibody-drug conjugate called trastuzumab emtansine, and also known as TDM1. And again, this study unfortunately was negative, and in fact, you can see that the study agent was performing worse for survival than just standard taxane alone. The physician had a choice of either giving docetaxel or paclitaxel in this study. And so you can see here, though, that a subgroup analysis showed again that patients with higher HER2 levels to begin with tended to derive some benefit from the TDM1 therapy. And again, big problems here would be that this temporal spatial heterogeneity problem, meaning they were HER2 positive when they were diagnosed, but going into second line, their cancer was no longer HER2 positive, was not reassessed. And so a lot of these patients would be HER2 negative. And so you're giving a smart bomb that's bringing this chemo agent to HER2 positive cells. But if you're HER2 negative, this agent's not going to be effective at all. And so you can see maybe that's even why it's worse than just standard chemotherapy. And another potential reason is that this agent emtansine, which is a microtubular chemotherapy inhibitor, may not be that active for gastroesophageal cancer. And so all these reasons would be why the GATSB study was negative. And then finally, the concept of using trastuzumab beyond progression, or TVP, is a concept that is useful in breast cancer and shown benefit in breast cancer, and has been assessed to some degree in this cancer. And so this would be if the patient had trastuzumab in the first line setting with the TOGA regimen, and then progressed on that regimen and now starting second-line therapy. This study called the TACT study, a randomized phase 2 study conducted in Asia, which randomized patients to either paclitaxel or and trastuzumab. And unfortunately, you can see here, there's no real difference in outcomes. I would really qualify that, though, with the fact that this temporal spatial heterogeneity issue was not addressed. And so all patients were eligible based on their diagnostic HER2 study. However, the investigators here made an effort to try and get biopsies after first-line progression prior to starting second-line therapy. And of those patients that they were able to get biopsies for, only less than a third of them were still HER2 positive. So 70% or so of the patients weren't having HER2 positive cancer. So we would not expect trastuzumab to be useful in those patients. And so we have to take this type of a study with a grain of salt. Yes, it's negative, but it doesn't ask the question about what if the patient still had HER2 positive disease, would continuing trastuzumab be useful there? So that's an important qualification. And remember, just a few slides to remind us what this heterogeneity looks like under the microscope. On the left side here, you have a HER2 IHC stain on the tumor cells. And you can see some of the tumor cells in brown are positive, but a whole bunch of the tumor cells are negative. So this is heterogeneity of the cancer, some positive, some negative. And on different immunohistochemistry or different gene protein, EGFR, is positive in all those other cells and negative in the HER2 positive cells. So this is an example of heterogeneity in the primary tumor in one biopsy. And then, of course, that can be extended to the primary tumor, but also other sites in the body, whether it be the liver or the lymph nodes or the lung or the bone, and over time, how things change. Here you see the different colors representing different genetic abnormalities in the cancer and how it's a dynamic thing that changes over time, especially when you have treatment in between where it's killing sensitive cells and leaving resistant cells behind. And so this is an example and reason why we would want to check at each time point before starting a new target therapy to ensure that that target is still present. This is a good study that was done called the GASTHER study that was assessing before and after first-line anti-HER2 based therapy. And what they showed was that a large proportion of patients had changes from positive to negative. What you can see here is that on the left side, our patients' tumors at first biopsy and second biopsy were HER2 positive. They didn't change, or they actually went up even. But then there's a large component of the patients that were assessed that were HER2 positive at baseline, but dropped significantly, in many cases to completely negative at the second biopsy. And so you would imagine that anti-HER2 therapy to be continued would not be very useful in this set of patients, whereas it may be useful in that set of patients that have persistent HER2 positivity. And that is exactly what they showed by looking at patients treated with that TDM1 trastuzumab and tansine therapy from, say, the Gatsby study. The patients who had persistent HER2 positivity seemed to derive benefit more than those who became negative, which makes a whole lot of sense. And then finally, to support all of these arguments, I've introduced our study called the Pangea study, looking at personalized antibodies for gastroesophageal adenocarcinoma, which looked at therapy through up to 3 lines of therapy, from FOLFOX to FOLFIRI, my preferred second-line chemo backbone, and then 5-FU and taxane in third line. And at each time point, assigning the patient to a matched targeted therapy based on what their biology of their cancer was doing at any given time. And so for HER2 positive tumors in the first line setting, they of course would get FOLFOX with trastuzumab. In the second line setting, if and when there's progression on FOLFOX and trastuzumab, they would switch to FOLFIRI. And if they were still HER2 positive, then they would get trastuzumab in the second line setting, so FOLFIRI with trastuzumab. On the other hand, if their cancer evolved to something else, they would get whatever best suited them at that given time. And so remember in that study, what we first showed was that we biopsied at baseline when patients were first diagnosed their primary tumor and their metastatic site. And if their treatment direction was changed, they would get their treatment based on the metastatic site, because ultimately that is a bigger problem than the primary tumor. And just looking at that simple assessment, of the 80 patients assessed, 35% of patients got a different treatment based on their metastatic site compared to their primary tumor site. But relevant to the discussion here today is, what about over time between first line and second line, or between second line and third line? You can see that of the patients assessed, up to half of them were switching their therapy from whatever they were on most previously, both between first and second, and between second and third line. And then most specifically to this video, for HER2 positive disease, at baseline, at diagnosis, about 3% of patients were positive only in the metastatic site and negative in the primary tumor. So this was an example of patients that otherwise wouldn't have gotten anti-HER2 therapy if we didn't go and seek the metastatic lesion. And in the reciprocal cases, where almost 20% of patients were positive for HER2 only in the primary tumor, but in the metastatic sites negative. And so this is an example where probably patients aren't deriving much benefit from the anti-HER2 therapy here. And then most relevant again to this video is between first and second line, and between second and third line, about half of patients converted to HER2 negative, even though they started with HER2 positive disease. And so again, an example of why would you give a patient that had HER2 negative cancer an anti-HER2 therapy? Doesn't make as much sense. So the outcomes of this study in all comers, we showed that the overall survival was higher than would be expected with a historical control. We also showed that in that treatment algorithm, that the patients at the higher groups of the algorithm did better than those at the lower end of the algorithm, which supports the reason for prioritizing biomarkers. HER2 is in the top group. And then again, most relevant to this video is that the HER2 positive group did exceedingly well here, with just FOLFOX trastuzumab, FOLFIRI trastuzumab, and then 5-FU taxane trastuzumab, if appropriate, and still HER2 positive over time, with a median survival of almost 26 months. And so this isn't with any novel therapies like pembrolizumab, if appropriate, or other anti-HER2 therapies that we're going to talk about. This was just with trastuzumab beyond progression and changing the chemo backbone in the appropriate setting. So that leads us to this last meta-analysis. Remember, a meta-analysis is a pooling of a whole bunch of different studies that are looking at the same question. And so this analysis was looking at, in this cancer type, whether or not trastuzumab beyond first progression was useful. And so a number of these studies are listed here. A is looking at overall survival, B is looking at progression-free survival, and C is looking at response rate. And what you see, remember, is a forest plot. And if the estimate in red is on the line, then there's no real difference. If it's to the left of the line, trastuzumab plus chemotherapy is better than what's on the right side, which is chemotherapy alone. And you can see here that of all the studies included, that some studies show no difference, other studies show a lot of difference, but a meta-analysis pools all the patients together, gives each study a certain weight based on the number of patients in the study, and then overall looks at what together that analysis produces. And you can see here that these black diamonds are the meta-analysis estimate, showing that that each of the clinical parameters, survival, progression-free survival, and response rate, are all better with the addition of trastuzumab plus chemo versus chemo alone. So this is supportive of trastuzumab beyond progression. In these studies, none of them prospectively confirmed that prior to starting their second line treatment that they still had HER2 positive cancer. Imagine if that was done and it excluded patients who were actually HER2 negative. These benefits might even be more profound. Then the last study to bring up before we move on to trastuzumab deruxtecan is this study that was recently published called the HER-RAM study. It makes a lot of sense that since ramucirumab per the Rainbow study became a standard of care of paclitaxel and ramucirumab in the second line, including in HER2 positive patients, is what if we add trastuzumab to paclitaxel and ramucirumab? Can that be beneficial for HER2 positive patients that have received first-line trastuzumab and then had progression? And so what it showed was it was a single-arm, non-randomized study of about 50 patients. And you can see here that the response rate was about 54%, and that the disease control rate was 96%. And the median progression-free survival is 7.1 months, and median overall survival 13.6 months. Now, importantly, because this is a more contemporary study, an effort again was made to assess prior to starting second-line therapy what the HER2 status was. And so of the 50 patients enrolled, almost half of them were assessed for this, so 23 of the patients, and 8 of those patients had HER2 negative biopsies. So just over a third of the patients enrolled were negative. And so what you can see also is that this is a very small analysis to assess whether or not there's benefit of adding trastuzumab in blue versus no trastuzumab, just the PAC-RAM in red. And so there's no real clear difference in progression-free survival, overall survival. But again, if we remember statistics in clinical trials, this has very low, if any, power to detect a difference, because paclitaxel ramucirumab is effective on and of itself. So you need a lot of patients to show the benefit on top of that with trastuzumab added. So that said, they made an effort to show, at least we can confirm the rate of evolution to HER2 negative. We showed 45%. Another study showed almost 70%, as I showed you. So that rate of evolution ranges from one study to the next. But the point is that probably the patients who derive continued anti-HER2 therapy are those that have persistent HER2 positive cancer. The other interesting thing that they did in this particular study was because it was a single arm study, it wasn't randomized, but they wanted to compare their outcomes to chemotherapy with paclitaxel and ramucirumab without the trastuzumab. And so they went back in Korea to look at their database of patients and their outcomes who were treated in second line with paclitaxel and ramucirumab and were HER2 positive. And of those 131 patients, you can see their outcomes here. Their outcomes for response was about 28%, stable disease about 50%, so disease control almost 80%, as opposed to what was seen in this study with a response rate of 54% and disease stability of 42%. And when we look at the outcomes to the actual phase 3 Rainbow study, these outcomes are very similar with their database of patients that are HER2 positive and receiving just paclitaxel and ramucirumab, which makes this result of this single arm study a little bit more credible. It's not randomized, it's not enough to change the standard of care, but it is supportive and suggestive that adding trastuzumab to paclitaxel and ramucirumab is going to improve outcomes for those patients. So summarizing everything we've talked about up to this point, what we see on this slide is all of the breast cancer studies and all of the gastroesophageal cancer studies, and through first-line therapy, through second-line therapy, and if they were positive, which is a green box versus negative with a red box. And what you can see here is that other than TOGA, all of the studies, both in first line and in second line, are negative. And we alluded to the reason for that being one of many, but a main one would be the molecular heterogeneity at baseline, and really certainly going into second line, making sure it's still positive. Now that brings us to the next drug, trastuzumab deruxtecan, which recently showed benefit in breast cancer, and then in a randomized phase 2 study called DESTINY Gastric 1 showed benefit in the third line setting of gastroesophageal cancer. So in addition to these chemotherapies we've already noted here, we're now going to add deruxtecan, which is another topoisomerase inhibitor 1, like irinotecan. Deruxtecan is more potent than irinotecan, and so yet it is in the same class of drugs. So in addition to the chemotherapy part with deruxtecan, remember in the introduction to targeted therapy and principles of targeted therapy video, where we differentiated two main class of treatments, antibodies and small molecules, It was the antibody drug conjugates, or ADCs, that we will now be focusing on, which is basically an antibody, in this case trastuzumab, which is linked to or conjugated to a chemo agent, in this case deruxtecan. We also, in the Gatsby study in a few slides ago, talked about TDM1, which is trastuzumab DM1, which is another chemocytotoxic agent. And again, just to highlight the biology and the structure of antibodies, where we have conventional antibodies like trastuzumab that bind to HER2. We have antibodies like margetuximab, which has an enhanced capability of antibody-dependent cell-mediated cytotoxicity. So it recruits natural killer cells and immune cells into the region by binding to the back end of the antibody. Trastuzumab does this, but margetuximab has been engineered to enhance that. We talked about bispecific antibodies like zanidatamab or ZW25, which has a binding of two different epitopes because it's a bivalent antibody or bispecific antibody. In that case, it's binding to both HER2 and HER3. And then we've talked about bispecific T cell engagers, which instead of binding to do two different epitopes on a target cell, it's binding to one epitope, HER2, on the target cell, and another epitope on a different cell, like a T cell, immune cell, to bring them together to enhance an immune response. These are also referred to as BiTEs. And then for us today, we're going to be talking about trastuzumab deruxtecan, which is an antibody drug conjugate, which binds to the epitopes of trastuzumab because it's on the trastuzumab antibody, but it's bound to deruxtecan, and that delivers the drug to the cell. There are also bispecific antibodies that could bind to more than one epitope, but trastuzumab deruxtecan is not one of those. Okay, so what did that study show? What was the properties of the study? So this study was a third-line study. So patients had already had at least 2 prior lines of therapy. Some actually had more than 3 lines of therapy. Half of the patients approximately were third line and half were fourth line or higher. It was conducted in Asia, and patients were randomized in a 2-to-1 fashion. So for every 3 patients enrolled, 2 got trastuzumab deruxtecan and 1 got chemotherapy. And the chemotherapy was physician's choice of either irinotecan or paclitaxel. Remember, this is in the third-line setting now. And so randomized phase 2 study, and it showed an improvement in response rate, 40% versus 14%. It showed an improvement in survival of about 4 months, absolute improvement, and an improvement in progression-free survival of about 2 months median. In terms of tolerability of this regimen, essentially, even though it's a, quote, targeted therapy, it is a chemotherapy. It has properties and side effects of a chemotherapy because it does have chemotherapy conjugated to the trastuzumab molecule. And so you can see here that any toxicity was common in both arms, in the chemotherapy arm or the trastuzumab deruxtecan arm. And it was actually a little bit higher incidence of grade 3-4 toxicity in the trastuzumab deruxtecan arm. And if you go through the list here, there's a lot of side effects that tend to be a little bit higher. Look at neutropenia, low blood counts is very common with this. And the one that I want to point out specifically, though, is the pneumonitis, which is inflammation in the lungs. And about 10% of patients had pneumonitis in this study. And some of those patients are grade 3 or 4 higher, which means you need oxygen and you're severely limited in your routine daily activities. So based on those results, trastuzumab deruxtecan, also known as Enhertu, was approved for the third line setting or higher shortly after these results were published. Interestingly, the FDA went ahead shortly thereafter and approved the agent for second line setting or higher. And so a few words about it were that there was a confirmed response rate of about 40% of patients enrolled. And in terms of this temporal spatial heterogeneity concept, This particular study in third line did not require a mandated reassessment by biopsy or other to ensure that the patient had HER2 positive cancer. That said, in unofficial reports, it's about 30% of patients did have a confirmatory biopsy. So that enriched the study for patients that had a confirmed HER2 positivity rate. In addition to that, because this is a contemporary study and what we've learned over the last decade, that it really should be checked is that many physicians considering to enroll their patient to this study may have checked their HER2 status either by a biopsy or by circulating tumor DNA quickly before enrolling their patient. And so there may be an unseen selection bias of patients that are actually HER2 positive still in the study because of this. So that said, in the FDA label of the approval, it does suggest to reassess HER2 status if it's feasible to obtain a new tumor specimen after prior trastuzumab-based therapy and before treatment with trastuzumab deruxtecan. And if the tumor biopsy is not available, we've also talked about circulating tumor DNA as a very reasonable, non-invasive, quick approach to ensure that the patient's tumor is actually still HER2 driven. So reassessing HER2 status is actually in the FDA label. And then finally, another thing in the label in what's called the black box warning is that interstitial lung disease or pneumonitis, as we've talked about, is a known risk. And the reason why I bring this up is because when we're talking about second line therapy, where this was a third line study, and we're talking about other agents that are already available to us in second line that don't cause this, and we're talking about balancing potential benefits and risks, it's my opinion, and it is only my opinion, that this agent probably should be reserved for later lines, not second line, for that reason. That said, also, the subgroup analysis of this study, again, every study tends to show a subgroup analysis by a forest plot. And you can see that one would show no difference between trastuzumab deruxtecan and chemotherapy. And this is looking at overall survival. And so you can see, again, in the overall cohort, there is benefit with TDXD compared to chemotherapy alone. But I've highlighted a few subgroups to pay attention to. The first is that the patients who had only 2 lines of prior therapy, so they were actually third line, seemed to derive less benefit than those that were in much later lines, which is interesting and of importance. As is typical when looking at biomarker stratification, those patients that had the highest levels of HER2 seemed to derive all the benefit, whereas those in the marginal IHC2 plus setting really didn't derive any benefit. And then finally, the patients that had a prior total gastrectomy seemed to do best compared to those who did not. And again, this is a small subgroup analysis, but it's interesting to see that. And the reason why I at least bring up the lines of therapy and the prior gastrectomy issue is that, does this really represent Western populations? At the beginning of this video, I mentioned that only about half of our patients proceed on to second line therapy, and even fewer onto later lines of therapy. And that's in stark contrast, actually, to in Asia, where a lot more patients go on to later lines of therapy. And there's a lot of reasons and possible hypotheses as to why that is, maybe different biology and other factors. But the fact is that this may not be representative of our patient population. And our patient population in second line, where there is now an approval, seems to, at least in this study, to derive a lot less benefit compared to paclitaxel alone, let alone paclitaxel and ramucirumab, which would be considered a standard like the rainbow regimen. And then also, unfortunately, in the United States and Western countries, most patients that are stage 4 are diagnosed with stage 4 as newly diagnosed stage 4, as opposed to earlier setting and then recurring. In contrast, in Asia, where they routinely screen all the population after the age of 40, for example, in Korea, they find earlier stages more frequently. And so more patients are getting gastrectomies. And so, again, this is where most of the benefit seems to lie, as opposed to if they were de novo, newly diagnosed stage 4 right from the get go, which is mostly our patients. So, again, does this study represent our patient population? And do the results represent our patient population in the second line setting? So, these are unanswered questions to date. However, the next follow-up study called DESTINY Gastric 2 was attempting to ask those questions. So this was a phase 2 study, single arm, not randomized, of patients to get in second line in the Western countries, including the United States. And a very important eligibility criteria here was that they had to get a biopsy and confirm centrally that it was HER2 positive. And so this is really now enriching for patients that actually have a chance of deriving benefit from this drug. That said, I can tell you from experience that this can take several weeks, even 3 weeks, 4 weeks sometimes, to get an answer if a patient is eligible, to get the biopsy set up, to get the biopsy sent, and to get a report and that it is or isn't HER2 positive. And so a lot of sicker patients that are progressing on first line therapy can't wait that long before they start their next line of therapy. And so by default, this study, and it's an eligibility requiring this biopsy and central confirmation, is a selection bias of better acting patients, if that makes sense. So patients that can wait and get that assessment. Patients that are sicker and can't wait that long were not enrolled in this study, period. So that has to be kept in mind. And we see it's a single arm study, and it was almost 80 patients. It was centrally confirmed and on biopsy after progression on first line therapy. The primary endpoint was response rate, and then other secondary endpoints like survival, progression-free survival, et cetera. So the good news is that this study now does represent a Western population. It's mostly male. It has mostly white patients, which is the majority of the patients we're seeing in North America with GE junction esophagus cancers. That's the risk factor. It's Caucasian males. And 2/3 approximately of the patients are GE junction esophagus, which are the patients we see. I will point out that another thing in favor of this study being positive is that it really enriched for a lot of patients that had a high HER2 expression, IHC3+. So if you remember some of the negative studies that I quoted in previous slides in this video, that rate was a lot lower, like in the 60% range. So remember, these drugs, all HER2 therapy drugs, seem to work best in the highest level of HER2, which makes sense. So if you've enriched for the study to have higher percentage of patients that have the highest level of HER2, that will make your study look better, okay? So in addition to the selection criteria of requiring a biopsy at baseline and basically that by default excluding sicker patients, and also as by design, only taking patients that have HER2 positive cancer at the time of starting second line, these are all things in favor of making this study drug look good. And so the results are shown here. The response rate was 38%, almost 40%. And there were a few complete responses. The disease control rate around 81%, and the progression-free survival 5.5. Now, I'm going to point out that in historical control comparison, we would see that the response rate would be about 28% with PAC-RAM, disease control rate pretty much the exact same, and the progression-free survival not much worse. I'll also point out, remember we showed you that the PAC-RAM subgroup of patients that were HER2 positive actually had a response rate of 45%. It was a small subgroup analysis, but that's what it was. And so just to show you and highlight that this study looks okay, but remembering the fact that it's got selection biases, these patients tend to be patients who are going to be doing better anyway because they could wait around for several weeks without treatment, and that they are confirmed to be HER2 positive and importantly enriched with IHC3+ tumors. these are all benefits that favor trastuzumab maybe unequally. So that said, I bring it up again, is that in this study, gastric 2, we see that the side effect profile, it is a chemotherapy agent. It causes significant toxicities, and the serious one being pneumonitis and interstitial lung disease. And that's shown here, where there was even a death, grade 5 toxicity is death from this agent, and the others were lower grade. But again, grade 2 is symptomatic shortness of breath affecting your daily living. And so that's still something to be aware of, that this is a side effect of this agent. And so there is, importantly, a large global randomized phase 3 study called DESTINY Gastric 4, which is basically comparing head-to-head rainbow, paclitaxel, ramucirumab, versus trastuzumab deruxtecan, TDXD. And so that study is ongoing. That said, it's important to note that this agent is already available in the second line setting in the United States or higher. And so I'm going to state my opinion, which you may sort of have deduced as we've been talking here, which is that other options, other good options, whether it be chemotherapy plus trastuzumab, the trastuzumab beyond progression, which has some evidence. My preference is a FOLFIRI regimen, but paclitaxel certainly, or docetaxel could be used. Or, of course, the robust pivotal rainbow regimen, which included HER2 positive tumors, chemo and ramucirumab, again, could be paclitaxel or irinotecan based. Or most recently, based on that HER-RAM study of chemotherapy, whether it be paclitaxel, ramucirumab, and trastuzumab, or irinotecan, ramucirumab, and trastuzumab, are all reasonable options that don't cause pneumonitis and don't cause this problem, which occurs in around 10% of the patients. And so we know that the drug's effective in third line, which is where it actually was studied, or higher. And so my preference is to keep it on hand and reserve it until later, when you've used up other options, which are pretty much as equally effective until proven otherwise in DESTINY Gastric 4, and spare the pneumonitis risk until later, when there's no other good option, and then it makes more sense and the risk-benefit profile has changed. That's my opinion, and those are the reasons for that opinion. I also want to point out an updated analysis that came with the actual publication. So these original rates of interstitial lung diseases, pneumonitis, were from the first data analysis and the presentation as an abstract form. Then later, the publication came out, and an updated analysis was performed, and you can see that these rates of pneumonitis and interstitial lung disease have increased. And so there's now 2 grade 5, for example, and 1 grade 4 toxicity. And I'll also point out that there are a few pneumonia cases, which sometimes are difficult to differentiate between drug-related pulmonary lung issues and an actual infection. And so conservatively, we would only include the pneumonitis and interstitial lung disease, but if we include these pneumonia cases, it increases even further. And so now with this updated analysis, any grade interstitial lung disease and pneumonitis is 15% of the patients enrolled with longer follow-up, of which 4% were at least grade 3, and 2 of which were deaths, grade 5. And then if we're a little bit more liberal and cautious and include the pneumonia cases as potentially related to the drug, this increases to nearly 20%. So this pulmonary toxicity from this drug is real. And you can see here with longer follow-up, suggesting that the longer patients are on therapy, the more likely they might develop this. And it is something to be aware of. And again, going back to the argument that we have other therapies that are equally as effective until proven otherwise with head-to-head studies, why add that added risk of pneumonitis when we could keep that drug for later when we will need it? And then the risk-benefit profile has changed, and we're willing to accept that added risk because there's no other better option. So in addition to those second-line options, of course, clinical trials are always preferred and recommended and encouraged. And so the DESTINY Gastric 4 study doesn't have sites or many sites in the United States, again, because in second line, which is where that study is being assessed, it's already approved here. So it's hard to accrue to such a study. However, there is another study called Mountaineer 2 study, which is for second line, a large global phase 3 study. And that is a head-to-head comparison of Rainbow, paclitaxel, ramucirumab, versus paclitaxel, ramucirumab, and, and trastuzumab and tucatinib. Tucatinib is that tyrosine kinase inhibitor that I pointed out at the beginning of the slides that inhibits the HER2 receptor. And so this is a building on that HER-RAM study that we saw from Korea, which was paclitaxel, ramucirumab, and trastuzumab, which showed promise, but unlikely to progress to a phase 3 study because neither ramucirumab nor trastuzumab has sponsor back has neither trastuzumab nor ramucirumab has their patent life remaining for the sponsors and the pharmaceutical companies to support such a study. However, tucatinib is a newer agent that has a longer patent, and so is assessing this this strategy. And it does make some sense because tucatinib by itself can be effective, but in most studies show that it really supports the effect of trastuzumab. So a third arm of paclitaxel, ramucirumab, and trastuzumab should probably be included in this because we've seen that it could be quite effective. However, I think that it doesn't, and that rather it's just this randomized study. And so everyone gets trastuzumab and tucatinib or placebos for those two agents. Other agents, we've talked about zanidatamab. It leapfrogged across the second line and is actually just assessing in the first line setting in the Horizon study. And remember, this is an antibody that binds to both HER2 and HER3, like the individual antibodies, trastuzumab and pertuzumab, but in this one antibody, bivalent, bispecific, does both. ZW49 is zanidatamab, but it's conjugated with a chemotherapy agent. And then there's a whole bunch of other really new agents and strategies like CAR-T and CAR-NK that are trying to stimulate the immune system and often bispecific to HER2 and other immune molecules. And then finally, I'll point out that TDXD and HER2, trastuzumab deruxtecan, has been assessed in low HER2, so not your classic HER2 positive cancers. So those that would be considered HER2 negative, IHC2 plus but FISH negative, or IHC1 plus. The reason for this is that it has shown benefit in breast cancer. And so there is a small analysis of a small number of patients, non-randomized, that seem to drive some benefit by responses, but in my opinion, lacking enough evidence to date to make that a standard option. And if warranted, should be done in larger studies before being assessed, because remember, breast cancer is a lot different than gastroesophageal cancer. We've seen a number of examples of that. So it would need to show more evidence before that becomes routinely used. So in this video, we've talked a lot about HER2-directed therapy. We reviewed what's done in the first line and updated based on the Keynote 811 study, that it's actually now, according to that press release, going to be limited to PD-L1 CPS score of 1 or higher for first line to add pembrolizumab to the TOGA regimen of chemo plus trastuzumab. And then in the second line setting, we reviewed the standard approach of paclitaxel and ramucirumab, or irinotecan-based therapy with ramucirumab, including for HER2 positive cancers. But then we talked about HER2-directed therapy. We went through a number of studies that were negative with lapatinib, TDM1, and even trastuzumab beyond progression, but also qualified particular reasons why that may be, and a main one being that a lot of those patients being enrolled were no longer HER2 positive and had evolved to HER2 negativity. And then we talked about how trastuzumab deruxtecan was showing benefit in the third line randomized study, received approval only in the United States in the second line setting, and that the gastric and that the second follow-up study, DESTINY Gastric 2 study, showed promising results in a single-arm study, but we have to keep that in mind that those patients were highly selected by a biopsy, some time frame before being enrolled. And so the ongoing head-to-head DESTINY Gastric 4 study will be very important to see whether or not it's actually better than paclitaxel and ramucirumab, and including whether it's tolerable in comparison to paclitaxel and ramucirumab, specifically the pneumonitis risk. And so, again, that's why trastuzumab deruxtecan is listed both as a second-line option or a third-line option, one or the other, or even later, if they haven't received it before. And so, again, my opinion has been that paclitaxel ramucirumab should be considered a standard for second-line, even HER2 positive, based on some information of trastuzumab beyond progression, with chemo plus trastuzumab. Again, I prefer FOLFIRI plus trastuzumab, but also could consider adding the trastuzumab to the paclitaxel and ramucirumab, like in the HER-RAM study. So until we have further analysis on these phase 3 studies, which include that DESTINY Gastric 4 study head-to-head of paclitaxel RAM versus trastuzumab deruxtecan, and the Mountaineer 2 study, which is paclitaxel RAM versus paclitaxel RAM, trastuzumab, and tucatinib. And so these two studies will be very important and may change the standard of care for that second-line setting globally. And again, they would have to compare to the benchmark outcomes of the Rainbow study to show benefit. So in the last video that we'll be talking about with respect to treatment in the metastatic setting, we'll be looking at third-line setting or higher, particularly for HER2 negative tumors. So in this video, we talked about second-line and later therapy for HER2. We talked about all of the considerations in terms of changing therapy from first line to second line, and whether or not one should repeat a biopsy or at least assess by circulating tumor DNA to ensure that the tumor is still HER2 positive before considering anti-HER2 therapy. We talked about a number of failed studies in the second line setting, but potential reasons why. And then we talked about trastuzumab deruxtecan and its uses in the third line setting, its approval in the second line setting, and ongoing studies to confirm whether or not it should be replacing paclitaxel RAM as a standard global second line option. Stay tuned for the next video on third line setting or higher for gastroesophageal adenocarcinoma. Thank you.